Okay, everyone, I think we're going to go ahead and get started. I know people are still streaming in, but good afternoon and welcome to the MacLean Center for Clinical Medical Ethics 43rd Annual Interdisciplinary Lecture Series. The theme of this year's series, as many of you know, are advocacy in healthcare and medicine. And before I have the chance to introduce our speaker from today, Dr. Howe, I want to remind everyone, so next week there will be no lecture because of the Thanksgiving break. And in 2 weeks, Dr. William Sage from Texas A&M University will be here. So please mark your calendars, invite your friends and colleagues. He'll be the next speaker in 2 weeks. But today we are delighted to host Dr. Edmund Howe. So Dr. Howe is the professor in the Department of Psychiatry, professor in the Department of Medicine, and director of programs in medical ethics at Uniformed Services University in Bethesda, Maryland. He is also senior scientist at USU's Center for the Study of Traumatic Stress. His research has focused on medical ethics with an emphasis on military medicine and clinical care at the end of life. He has served as the founding editor-in-chief of the Journal of Clinical Ethics, which is published on behalf of the MacLean Center and here at the University of Chicago now, and a previous president of the Academy of Medicine in Washington, D.C., serving as chair of the Medical Student Subcommittee for over 2 decades. He is also chair of the Human Institutional Review Board at USU and has chaired the Ethics Subcommittee of the Society of Medical Consultants to the Armed Forces. Dr. Howe, it's a pleasure to have you here, and everyone please give him a warm welcome.
Thank you, Micah. It is, of course, a real honor to be here. And I particularly would like to thank a number of people and recognize them who have been involved with me in both coming here today and in having the Journal of Clinical Ethics, come out of Chicago, as opposed to where it was for close to 35 years before them. And so Dr. Angelos, of course, is like to thank him. I met earlier with Marshall and Micah, if you'll forgive my first names, and it was great meeting them and talking with them. And Joseph Musinski, I want to be sure I got his name right, is the sort of managing editor out of Chicago for the Journal of Clinical Ethics, and he has done a magnificent job. And last but not least, Haley and Leaveview have done magnificent jobs of, for somebody like me who gets lost about everything, being able to get organized and be here. Well, what I'm going to talk about today is I was actually given a clean slate of saying whatever I thought might be worth saying about boundaries. And so my topic is going to be, as you can see, boundaries or bonding. And incidentally, my email is here as well as over there. This will stay up here because I'm so used to slides showing emails and speakers saying, email me if you have something that you'd like to talk about. But then the slide is going in 2 seconds before you can write it down. So you can sit back and relax and take your time. I'm going to share with you a bias today, which is a bias. I'm a psychiatrist, and perhaps for that reason, in part, I value greatly the relationship between providers and patients and families more than anything else. And that will become clear as we go ahead. And so as I talk about boundaries and their limits, the aim of that is to enhance the relationship between providers and patients and families. And so I'm going to be covering a number of areas. The topic of this might be all the ways in which you might want to enhance your relationships, including by how you set, or rather don't set boundaries, which we'll be talking about shortly, all those that you may not know of. And so as you leave the door today, about an hour from now, something like that, I'm looking forward greatly to the discussion after that, I'm hoping that you'll all maybe have a trick or two that you haven't thought of that you might want to adopt in your practice, however you interact with patients and families, if you do. Now, I want to give credit to Autumn Feaster. I'm told you pronounce her name Feaster. I know her personally, but I always refer to her as Autumn, in that she has done a great deal of writing and talking and influenced me profoundly over time. I mention her in part because I recommend you look up Fiester, any and all of her works, because it will be spelling out the sort of things I'm saying a little bit here, and I'll point out what she said twice during my talk. And the other person that I'd refer you to, they're both in the references, is Jody Halpern. She's a psychiatrist and philosopher who talks about the positive aspects of paternalism, which I'll get to shortly. All right. Disclaimer, these are my views only. Now, this will be our paradigm of what we may not want to do. And I have run into this over decades of practice, not infrequently, where a patient or family gets a little bit out of order and the staff person says, your behavior is unacceptable. Well, I would submit to you that that may be the beginning of a breach in the relationship, though its intent is to set a boundary, and many people are instructed in both formal meetings of the ASBH that I've been at, as well as in their medical training, to set a boundary. We'll return to that. Now, there are three empirical considerations worth, even though they're obvious, taking a moment with. And that is that we all have, most likely, maybe not some of you, some of us, I shouldn't say us, Achilles heels. That is areas in which we feel super vulnerable. That being the case, every patient and family member you're seeing, it could be that they have great fear. And reasonably so, because of course they have illness and they're afraid of what's going to go on. And psychologically, of course, fear tends to prevail over other emotions that conflict. And so that the patient and family you're seeing are likely to have fear, and regardless of what they show then, forming the bond that you want may mean understanding that fear and making that a priority above everything else. Oh boy. Anyone know how to get this back on? Oh, okay, you can see I can. Would you like to turn the system on? Yes, maybe. Sorry, I lost my being able to see this here. Okay, it went back on. Fair enough. Mind of its own, off again. Thank you. And it'll keep on going. Thank you. Sorry about that. Now, people are often taught, people meaning medical students and docs, that to bond, if you will, repeat the last 5 words that the patient says. That will suggest that you understand them. My first suggestion is that you not do that, but rather you paraphrase. Otherwise, your repeating can become a cliche that comes across automatically. And as I'll be talking about some subtle nonverbal events that can take place, you can get into a mind of responding to a cliche, which may come through nonverbally. Thus, I suggest you paraphrase rather than repeat. And you always can find something that the patient says that you can relate to and validate. In terms of initially meeting, when the patient says, this is my concern, and you then say, okay, let me see if I got that right. This makes sense to me. Is this it? There, the patient feels you're one alongside them and an ally working together on what they want to solve, as opposed to the doc in power and the patient or family not. In that you might see that as the major obstacle to be overcome in all relationships. Now, what we tend to do is, just as I did, I said, okay, so this is, do I got this right? Now note, I did that as a singular, but often patients will have, as they explain to you what they're struggling with, 10 things they're afraid of. And so you mention 6 or 9. Do I got it? The patient, yes, wants to please. So the patient says, yeah. But note how I just said that. It was sort of a lukewarm, yeah. When in fact, I missed something important to the patient. So, and this is an Autumn Feaster point, that ideally you want to keep on going until you get nonverbal verification. Suddenly saying, did I get it right? These 10 points, they say, yes. Then you're there. So you're looking for the nonverbal verification that you got where the patient is coming from, that you got all the patient's fears so that then you can work together to solving them. Now, you may have difficulty figuring out what the patient's afraid of. So you keep going. Oh boy, I don't have time. That's bad, and so on. Note that, of course, the fact that you're trying to figure out what the patient's struggling with, the mere fact of trying, even though you don't get it, will speak for itself and help with the bonding. So that you get to the point where the patient non-verbally says, yep, you did it, you got it. Okay, now there's some ethicists who've even written about this in books about it, that when you go into an ethics conflict, which is for simple purposes, where there's 2 people who have a mutually exclusive point of view, whether it be docs, nurses, patients, or family, the question is, how can you do best then? And Autumn Feister's notion, she's a mediation person, is starting with not what people's positions are, but what underlies them in terms of what they value and find more meaningful. And she reports being able to, by being non-judgmental and pursuing that with everyone, getting to, in virtually all, and she might say all cases, and point where people care about each other as opposed to hating them, if you will, for taking different positions. There are problems with setting ground rules, however, because that's exactly what I'm railing against, if you will. Okay, here's the ground rules. Nobody raised their voice. Nobody say something that's unkind. We're civil and trying to discuss this huge disagreement that's critical to all of us. Because if you set a ground rule, then of course that's first establishing your power, which will have problems with bonding from the get-go. But also then if somebody violates the ground rules, all of a sudden you're labeling them as a person within the group who's not following the rules and is therefore a pariah of sorts. Now let's step aside for a minute. I'm not talking about when a patient or family member makes some sort of physical threat. Then it's totally different ball game, totally different algorithm and flowchart. Then one wants to, of course, call security for obvious reasons. One doesn't want to take on any sort of physical risk of any sort. But we're going to talk a little bit differently about verbal abuse that a patient or family may give you, because that's where we've learned and are taught we've got to set boundaries. So what one wants to start with here is the notion that docs, by mere nature of that they give orders, have power, and for patients and families, that's always an issue. Now, when one utters something which has the inkling of being an order, all sorts of language that can do that, I would suggest that we are all prone to what's referred to as an oppositional reaction, an immediate reaction. You know, I was thinking prior to coming here of doing an experiential thing, and so I think I've decided against my better judgment to go ahead and do it. So, stand up. Don't. My point is, however, address what you felt when I said that, even for a split second. You might have felt to tell me where to go with that, because I was telling you what to do, and that's an example of an automatic oppositional response we have that may have been important for all of us throughout our survival, to sometimes put on the brakes, to see what we're going to do. So one wants to avoid that, and that's the overall view of where we're going with this. Now, in terms of how patients might respond, or families, when you're speaking with them, is it they may, wanting to get the best treatment, of course, respond by being silent, even though they're thinking, how am I going to outwit the doc and get the best I can out of this when he, she, they are giving me orders. And silence is worse here than anger, because you may not know that the patient is trying to figure out how to outwit you, since you have the power. But if they're angry, then one has an inkling that that may be because they have fear, and fear they aren't being understood, and therefore their anger comes from that. And that's then the rationale for the intervention I'll be suggesting. Now let's step back for a minute to be at the bedside in the hospital. And yes, if patients are racist, sexist, or just plain nasty and continue to be that way, okay, our typical, and you might disagree with me on that, but I certainly have heard it throughout my career again and again. Okay, if you're a provider of whatever sort, you've got to be tough. That's your job. Okay, so if the patient is nasty in any of these ways, put your foot down. Part of being a doc, part of being a nurse, right? Well, I'd like to suggest something opposite to that. And that's my big point of this discussion. And that is when the patient is angry, as opposed to setting a limit or boundary, as in saying this is unacceptable, to make as your mission to understand in the way that we referred to earlier. Now, what about the patient who's psychopathic? So that you've tried to understand and responded as best you can, and they've continued to be any of these ways, racist, sexist, nasty. Well, again, what is the ground rule? And you may disagree with me on that. The ground rule is to, you're tough, you're a doc, that's your job, not to put up with this stuff. And so you then go back in again 4 hours later, because that's your job, and the person is abusive again. And what happens then? What happens then is some of us, perhaps all of us, might be sensitive to that abuse and traumatized by it. And you know the phrase that one can't sleep at night, but it can be that one can't sleep for nights because of what a patient has done. So I'd like to suggest to you another possibility that you don't know of often, and this again comes from Autumn, and that is to, if the person is psychopathic, or so it seems by their being continually abusive, to consider having as your first priority protecting the provider from that emotional abuse. Any number of ways you could do that. I'll mention just two. One is the next time send in two people so that that person, that provider, will have some protection. And that way, the other is to actually switch providers. Now, some people say, gee, if you're going to do that, you're going to be reinforcing the abusive behavior. If the patient hasn't, for example, wanted a male provider and they're complaining about that and being abusive, so you suddenly provide a female provider, you've reinforced their abuse. Well, that logically makes sense, but the big picture here is to protect all providers from any sort of trauma that can come about. Now, on to some other means of bonding that are perhaps not in our common thinking. And here, docs can often, of course, and I refer to docs, any types of providers, they can have the best of intentions that can bomb royally. And the example I'm referring here, there's one where a child was born with Down syndrome, and the doc shortly thereafter said, I'm sorry that your child was born with this condition. And the intention was to recognize what could be the case. The mother was, of course, I say of course, outraged, and outraged 20 years later. That continued to hurt. Just an example of where providers can have the best intention, but it can bomb royally. So what should one do then? Well, typically one would want to say, I'm sorry. And though the lawyers may say, gee, don't say that, because then they can use that as a ground for suit. Well, the provider said they were sorry after all, so they admit their mistake. Then, of course, one wants to say, what can I do? But what I would like to suggest is a third thing which you may not have considered. And that is, all patients may not take your saying that you're sorry at face value, perhaps because of even how you say it. So you might want to consider saying something like, and I will vow to never do this again to the extent that I can succeed in that to anyone, with that sort of emphasis. Now, providers might say, gee, I'm not going to say that. That's just going too far. Well, my question is it, if your goal is to form an alliance with the patient, in this instance, showing that you really mean that you're sorry? Now, in this particular instance, if one just looks at the title, Mistakes, Child with Down Syndrome, you could read that in another way as not introducing the attention versus effect discrepancy that I've referred to, but you could see that as prejudicial against infants, people with Down syndrome. That is, there's an ambiguity there. And I'll talk a little bit more about ambiguities in a few minutes. But note that all language tends to have possible ambiguities. And I just want to tell you one terrible story. It's a true thing that happened. There was a doc who suddenly learned more about ethics. And okay, you've got to be sure people are adequately informed. And there was a patient about 50 years old who'd been in the hospital for some time. She had to live there because she needed a treatment every day there. And she had a big family, fortunately, so they could divvy up her day and have somebody be with her and join her each day. And both the family and she had what they considered a great life. So the doctor who'd learned about ethics, you've got to inform people, said, gee, maybe she doesn't know that she could refuse these treatments and then let her family go on with their lives and not break up every day with somebody visiting her. So this doc went up and told her that. She, the next day, and died because she thought he was telling her that she should stop treatments and die to free up her family. His intention was not that at all. It was just to inform her that she had that option in case she didn't know it. I'll talk about what to do about ambiguities in this next slide. Note that words one uses can violate the relationship just with a wrong word. Example, and I must say, I and other people in the room, as a psychiatrist, as you talk with people and after some time together, they trust you and then share how they've responded to events that have happened in the past. You have some inklings perhaps that you might not have been aware of, and this is one of them. The doc who's late and says, yeah, I'm late, sorry, you're upset. And note that you puts them and at fault, in a sense, for being upset, or at least that's how some patients take it. Rather than that, if one switches from the you to the I, sorry, I was late, it puts me in the seat as having created it, and I apologize. So words are important. Now, that's very subtle, and some of you might say, who cares, but it can have effect. So I want to go on to a clearer example, and one that is, in fact, ambivalent as well. And that is, patient comes in, and they say, oh, I'm in terrible pain. And they don't have an objective set of findings that go with that. And so you're thinking they may be exaggerating. And some of you know a word we used to use before some of you were born, much more the word histrionic as a way of describing that. It's a sort of pejorative term, perhaps. So we think the patient might be exaggerating. So we maybe say, gee, if I say, well, tell me more about your pain or your terrible pain, I'm going to be reinforcing it, right? Creating it just like a placebo effect. Well, maybe not at all. And more than that, maybe if I then say to avoid that, what I see as a placebo effect, by saying, well, can we talk about your discomfort? The patient is going to hear that and hear that as you're minimizing what they're experiencing. End of relationship right there. So that one wants to consider using the same words that the patient uses that at least don't diminish or infantilize them. Now, back to ambiguity, now that we've looked at words a little bit. Data shows that people that are depressed and fearful, which are by definition all our patients, they're likely to literally see more ambiguity in phrases than others. And they're likely to see then the worst meaning toward them in the ambiguous statement. So what does that mean? In an ongoing way with patients and families, one wants to cover keeping aware of what one might say that could have an ambiguous meaning. If so, one can spot it, identify it, and before one says what could be ambiguous, to clarify to the patient that, look, I'm about to say this, I don't know a better way to say it, but you could take this in a way I don't mean it, so let me alert you. And how do patients respond then? Wow, thank you, got it. If one doesn't detect something ambiguous, but picks it up again non-verbally, one can then respond and ask, what did I say then? Did I say something that was somehow hit you the way I didn't mean it because I didn't mean to? And they say yes, or they say no. And if they say yes, I thought you were saying this, that you were saying I should die, going back to that patient. No, that isn't what I was saying at all. And then one can, of course, correct it. Rules. And I was having a wonderful talk with Micah about this shortly before this meeting. And here, there's an importance to always looking for exceptions because every case may have idiosyncratic features. And just to give you some dumb, perhaps, examples, but they will serve the purpose. Okay, so you're home having dinner. Micah, you're with your family. And all of a sudden you have a patient who's figured out how to call you at home. You may have their number. They're out of sleep meds and they're terrified. They've just discovered it, of going sleepless through Friday night. Well, that's painful, not sleeping. So it might be that you then want to find a way to see if you can find a 24-hour pharmacy that will accept your prescription so they can sleep. Any number of examples here. One is people who've been medically boarded and then get some sort of compensation. They have to go back often to be reassessed. And that can be terrifying. Well, it can be greatly bonding if you're able to somehow take off a few hours to be with the patient as they go for that. Or finally, the patient may need to go to court, which is terrifying as well. As a third example, if you can get free and do that, that may be the sort of unique experience that patients may feel bonded forever, and rightfully so. So worth thinking of. Now, somebody might say, wait a minute, that's not, no, forget it. Forget it, why? Well, because that sets a precedent. I can't take off every Friday night from my family, right? Might be not a good idea to then be with a patient. But because one does something once, doesn't mean one has to be bound by this notion of precedence. Slippery slopes is another concept that can trip people up on doing their best by patients. Now, there are three types of slippery slopes. Okay, one is in principle. If the morally relevant factors are exactly the same, in principle, if one acts one way in one instance, and for the next case, 37-year-old man, the only difference is a 38-year-old man, to be consistent, one should do the same thing in each case on the basis of principle. Fair enough. That's a valid slippery slope argument. It doesn't mean just because one's been consistent, however, that one's done the right thing. Important fallacy to not buy into. Second slippery slope. I'm going to test right now. Who among you is a good person? You ready? So I'm walking up the stairs. Aren't any of you going to tackle me? Because if I keep on going, I'll walk. Unfortunately, I don't have my bearings here. But if the lever east, I walk into the Atlantic Ocean and drown. Well, that's absurd, of course. That's an invalid slippery slope argument. If we do this, we're going to keep on doing it. So you don't want to, you want to make that distinction when you're thinking of slippery slopes. Does it help with consistency? And if it's consistent, okay, it's less likely to be arbitrary, but not necessarily right. On the other hand, if it's an empirical claim, it may be garbage. Third slippery slope argument, one that's been applied particularly to the Netherlands, and that is saying that, gee, if docs participate in euthanasia, they're going to get callous to it and keep on doing and do more and more. Bad result. Well, that's an assumption. In fact, talking with Netherlands physicians who have participated in active euthanasia, they say it's very hard. At best, they might be able to do it a couple times a year because it's hard to get over. So one doesn't want to make psychological claims without then questioning them. Now, my favorite example of making an exception is the last one here. And this is real, where there was a family whose loved one had brain death, but they believed in the patient still being alive because this patient's heart was ticking. And the staff was unwilling and or unable to go ahead and keep the patient on the respirator, and one would say in quote, life-prolonging measures as the family wanted. But what they said is, okay, what we will do is call up New Jersey, a hospital there, where they can keep your loved one on a respirator and see if we can arrange that. Now, it turned out the patient died, but that family was forever appreciative of that family's effort. So even though our rules, one wants to always think, could there be an exception that would represent bonding with the patient optimally, which is, I might suggest, what one wants to work for, that one might be as dedicated to one's patients and vice versa as to one's family members. A controversial claim, I know, maybe we'll get to it during the discussion. All right, so then you're on the ward and you have an ethical conflict and you're getting together the family, patient, staff, and they're all disagreeing. What's one of the principles that you want to operate there? It's to have everyone speak, because that way you can have all the morally relevant factors on the table and considered, and then you're likely to have a better analysis. So that is critical, hard to bring about, but critical. Now, the law, and we'll talk more about the law in a minute. You have your lawyer on the ethics committee. Now, he, she, they ideally will know that they have two hats. One, they're being the lawyer for the hospital, where they might say to the head of the hospital, look, as your hospital lawyer, we have 1 out of 10,000 chance of getting sued if we do this. But in my role as an ethics committee member, thinking what's ethical, this is a certainty that unless we do this, the patient will be more harmed. That's a skill lawyers should have. Ethics committees also can, of course, if they get stuck in terms of getting other viewpoints, go to an outside committee, a nearby hospital that has an ethics committee that likely is going to be happy to offer a possible opinion. And what happens if you get stuck in the committee earlier on, where you can keep going until those in power argue more strongly for their point of view? But a better way might well be to say, okay, is it time, since reasonable persons reasonably disagree in our committee or our group, whether on the ward or an ethics committee, to switch the question from what should be done to who should decide when reasonable persons may reasonably disagree. And there's likely to be not only much greater agreement, but a sound basis for deciding what procedure you're going to do. Speaks to the limitations of ethics in terms of coming up with right answers, but they might be less limited ethics in coming up with right procedures. Now, one wants to, of course, recognize that there's an ethical issue, and that's the first task here. So for any of you, again, that have been around for several decades, you might recall that in terms of the insanity defense, there was at one time two prongs of it. One, did the person know right from wrong? Second, could they control their behavior? And so there, for those assessing those patients for insanity, under the second prong, they would ask themselves, okay, they'd use the police person at the elbow test, which is if there were a police person at their side, would they still have done the crime? I'd like to suggest a different hypothetical exercise for you for all your patients, which is to say, if this patient were a billionaire and they had a loved one who was an expert in their medical illness and in ethics in regard to their situation and in law in regard to their situation, would they make the same choice? Would they get the same treatment? If not, by definition, there's then an inequity going on, which then raises the question of, should you address it? The question of justice. Well, as you all may know, for every ethics case you run into, you can actually spend the rest of your lives literally doing the following: testing how you've come out and saying, okay, I want to now look at other cases that I know of that have the same morally relevant features, and only those. Would I come out the same way? Or you could look at what could be real cases that could occur, but they simply haven't yet, but they could. And the biggie here is science fiction case, which any of you working in philosophy and ethics know that it's fair game to come up with a science fiction example to test the consistency of one's conclusion for a case before oneself. Okay, I'll give you one real quick. We talked about the baby born with Down syndrome years ago, and the first time this occurred, parents were asked, okay, your baby has Down syndrome and intestinal atresia. Can we operate on your baby so that your baby can live a full life? And the parents said no. And then that brought about a whole set of rules of what parents could and couldn't decide. Well, let's say you were part of that ethics committee, assuming there was, I'm not assuming that, but hypothetically. And so that you said, yeah, the parents should decide. And then you wanted to test that as opposed to just walk back to your ward and take care of patients. And then suddenly you consider me. Now, this may be hard for some of you. I'm joking. Consider me, and you're asking the question of, we're taken over by persons from Mars, and their average IQ is 200, and our average IQ is 100. And then I get appendicitis, and let's assume that antibiotics won't treat it. So the question comes up, should I have an operation, an appendectomy? And the persons from Mars, all with IQs of 200, they say no. I have less cognition than they do, less intelligence, whatever you want to call it. So they aren't going to operate on me. Well, you have to decide then, how do you like the idea of not operating on me as opposed to doing the appendectomy? If you don't like that, then you might look back at the situation of the baby with Down syndrome and intestinal atresia and say, nope, that decision made years ago in Indiana shouldn't fly. So that's how you can use science fiction for the rest of your careers to test every decision you make, should you want to. And I know you won't, though you may have felt it fine for me to not have the appendectomy, having heard me thus far. Good joke. Okay. And finally, of course, what we want to do is to, when one has a case, to look at similar cases that differ in some small degree and line them up along a spectrum, and then figure out where you draw the line. To the right of all of them, to the left of all of them, somewhere in the middle, and then why. And then you and colleagues disagreeing can find out exactly how precisely you differ on where that line should be drawn. Now, there are also different frameworks, of course, and people often, I'm sure you've run into this, they say, well, the first question is, okay, what's the law? As if the law should determine what one should do. Now, I'm not going off on the cliche here of, well, the law is the law and laws and ethics and so on. We all know that one. But let me suggest that often, more often maybe than we think of, one can have options that are outside the law. Example was the case I was involved in at NIH, for that matter. And this had to do with a man who was middle-aged, and he had cancer that was going to take his life in 6 months, and he was at that time in a coma. And someone knew whether he'd want to have treatment to keep him alive for that 6 months or so. And his wife said he wouldn't. He talked about it with her, and he wouldn't want to be kept alive. His family, however, of which there were many, they said, no, we disagree, wife. He's a fighter. He would want to be kept alive for 6 months. Mutually exclusive, total disagreement. What did the law say, and what does it say in most states? It says, okay, you got to be lexical. Okay, first you go by partners, and then you go by adult children, and only then you go by adult parents, for example. But that doesn't preclude you doing what we did in that case. We said, okay, there are two ways that you can go here. We can go by the law, and wife, you can decide, and then family, your task might be to forgive her if you're willing to. Or you could all sit down and see if you can come up with something that you can agree on and feel good about. And that, of course, speaks to the goal that I've urged throughout this of being able to walk out all hand in hand at the end of the hospital stay. Okay, narrative approach is critical also as another framework. And what that means is that we are always, in what we know about any patient or family, stereotyping constantly from what little we know. More information can save. That actually, I'll give you a quick case on this. There was a young man, child with Werdnig-Hoffmann's disease, which is actually like an infant Lou Gehrig's disease that you get weaker and weaker and then die. And so there were all sorts of experts that were involved in this case, and they all said, well, yes, we shouldn't cause more suffering by keeping this child alive. I then went after that ethics committee meeting and went to the ward, and the child was in there with his family, and there was bubbling laughter. It was coming out of that room. I said, what's going on? Is it the right room? Now, some of you might think it's unethical that I stood out there and meet talk, which you did, and you might be right in that. Anyway, I then came in and found out that this child and this family, as opposed to being in grief because the child will be dying in a couple months, as the ethics committee had zoomed, this family was exuberant, loving every second of it from what I saw. And it made sense because they had a very strong religion, and the clergyman was there, and so they, to them, their child was going to be in heaven, and they'd all meet again soon. It was just a matter of time. And so then I considered, gee, this family situation is different from what the ethics committee imagined. Maybe I should contact the committee and ask them to re-get together. I might want to go a different way. I didn't, and some people might say I should have, and maybe right in that, but I didn't. But what this illustrates is the importance of overcoming one's assumptions by getting more information with what is known as the narrative approach. And then one also wants to consider casuistry, where my shorthand is. One asks what other cases one knows of that intuitively seem to suggest going a different direction. That's hard to then argue about in abstract concepts, but it means putting some moral weight on your intuition. And one then asks, what past cases do I know of that may influence me? Okay, when one's meeting with ethics committees or staff, one wants patients and families to feel safe. Much work on that. How do you do that? You ask patients and family who they'd want to be with them to feel safe when there are 6 staff and just them. Maybe they need 6 family members to feel safe. Worth going after, even though you may get some flack from your staff. And you can always say to every patient, when you're their primary care provider, look, here's the deal, this ethical issue. I've just gotten wind that it could be coming about, and I want you to know that I will do all I can to work for your interest, even if I disagree 180 degrees from how you come out. That means, for example, guiding them through making appeals, even perhaps setting up an appeal procedure if that's going to be possible. You want to explain to patients in terms of bonding why you're going to do what you do before you do it, so that they're then, again, part of your alliance. Now, the question is how far to go here in terms of bonding. And my favorite example asking this question is what some providers do when somebody is coming in and they need oxygen at home. And there's some law, as there is in some states, that, okay, if it's a certain amount of oxygen, you get it free from the state. But on the other hand, if you only need a little bit of oxygen, when your oxygen levels are tested, then you won't get it. So what some docs do is they have the patient walk around for half an hour before they come in, and then they take their oxygen levels. Well, is that gaming the system? And of course, that raises a whole set of questions as to whether docs should ever game the system. We won't go there right now. But the other question one might ask is, what if you won't, but happen to know that your neighbor will? Well, should you say that? Should you say, well, you could go and see my colleague next door because you don't have a lot of money and need oxygen? Well, one can also take that further and ask the question of, should you be transparent in sharing with your patient why your colleague will do that and game the system, but you won't, such as relative to that, your colleague, you would see yourself as maybe a little bit cowardly, not willing to take the risk, whereas they aren't. Tough questions, worth, however, at least considering. Okay, there are some controversies that we've just begun to go into. I'm just going to mention them. There's a whole set of therapy that you may not have heard of called paradoxical intention therapy. And you can look up David Mealy, what he would do when he would have patients such as those with schizophrenia who'd come in and say, I'm not going to take my med. It won't help me. Instead of then going into a conflict, David Mealy would say, okay, maybe you're right. And maybe we can test that out and do some research together, again, as allies. How about you go for length of time without medication and see how it works, and then we'll try a medication and see which works better. Now, Mealy points out the fact that if you're going to do that, you better warn the staff that's what you're going to do to stay out of trouble. Another person I refer you to here is Leston Havens, who used to be the director of psychiatry for residents up at Harvard for years. He would, when a patient who was paranoid, he was known for actually being perhaps the best person ever at treating patients who had paranoia. And if the patient would say, well, there's an exit there, and maybe somebody would bring about the event. Havens would say, as a person, you think that, but I don't think that, which is what most people would say. He would say, look, how about this? I'll go up these stairs, and I'll go there, and all this things, big thing, and I'll smash them out there. You want to come with me? And then the patient's likely to say, oh, well, I'm not that sure that there's something out there. What people call that is a flight in health, which people even with psychoses can do when they're in the hospital and, for example, have to go to the dentist. Their mind becomes clear for about that hour very often. And that also can, for Havens, and he's written about it, you might want to read about him, look it up. And then finally, Jay Haley, for those of you that don't know of him, and more recently, Chloe, Chloe Madanes, Madanes. They both write about, for patients who are totally locked into oppositional behaviors, what they do is actually encourage, much like Havens did, taking those oppositional behaviors further until the patient again walks and gives up the behavior because the therapist has taken over what they're doing. Well, then there are questions that are controversial as how much should one self-disclose, but it's worth considering. For example, the patient who comes in and says, gee, I almost didn't come in, I didn't want to. One can say, yeah, I get that. That's how I get whenever I think I got to go to the dentist. Again, it gets scary. Worth thinking about, as well as touching and crying before patients that we won't talk about, but suffice it to say that there are some parents who've experienced terribly tragic outcomes for the young children who 20 years later, all they remember is that there was a dog who cried, and that meant so much to them. The one bright spot at the end of the tunnel. If, coming toward conclusion now, you find yourself obsessing about some case, that's likely to be a cue to you that there's an ethical issue going on that's been unrecognized. It's sort of, if you forgive me, like Freud said, a dream is the royal road to the unconscious. So one might say that obsessing is the royal road that an ethical issue is going on unrecognized. Note, your non-verbal responses can do you in. You're talking to the patient and have one eyebrow go up as if to say, as some people do, what? And that may, again, kill your relationship, surviving to imagine that. But then you want to note the nonverbal behavior and explore it. And you probably run into, all of you, I certainly have enough that I expect this. There's the family who are trying to decide what to do for the patient who can't speak for him, her, or themselves. And so it looks like to the staff that maybe they're trying to make the decision they are keeping dad alive so that they can get Social Security checks and continue to get money. Okay, so they're detectives. Now, question I'd raise for you is, can one non-verbally be optimally fully empathic at the same time that one is playing detective in one's mind? Maybe not. You can answer that for yourself. But if not, there are certain different responses you might make other than playing detective. I mentioned Jody Halpern, and she talks about good paternalism. And here the idea is, we could talk about paternalism for hours and so on. It's, of course, docs making decisions for other people and that they think are best. And then we've decided not to do that because that's bad to do. But what Jody talks about is when patients are afraid, they often miss out. They don't think of stuff important to them. Whereas if you do, as a provider, might be most important to give the best care, to then share, gee, have you thought about this thought that you might have, and so on. And she gives some wonderful examples in her book, which is in your references, which I'd recommend. She has regrets to this day for a patient who had 2 leg amputations and wanted to refuse treatment. Jody regrets not having said, gee, might there be something else in life that we could discuss? Or for another patient at a conference she was talking about who wanted to go to another land. He tried all sorts of treatments to see if he could possibly get an experimental phase 1 treatment to live, but that would be dying without his family. And so she thought there it was saying, look, is this really how you want to die? Now, if there's one controversial issue I want to last year with you, is the use of humor. And that's always iffy, of course, if patients are sick, but it can be profoundly bonding, as Viktor Frankl has told us, where he talks about meaning and the importance of humor. And in that regard, one can always ask patients if it's okay to use humor first. One can then use self-depreciating humor at one's own expense, which can be, and then the final goal that might be ideal is if the patient can bond sufficiently to laugh at you, with you. As in this example here, there was a patient who had profound physical problems, and I couldn't get an appointment, and so I used my physician identity to see if I could get him an early appointment. And could. Controversial ethically, of course, in and of itself. And then this came up several months later, where I made the offer again, and he said, no, thanks, doc. I got one more thing I can try. But if it doesn't work, I'll sick you on him. So it's an example of perhaps where one wants to get to if one's trying to go as far with bonding as one can. So final points here. Emotions empirically tend to take precedence over facts. In this regard, connotations take precedence over denotations. So a case to perhaps illustrate this is the patient who comes in dying, has kidney failure, and one could start kidney dialysis, maybe keep the patient alive for 2 weeks, but only 2 weeks longer. The family want it, the patient wants it, but the staff sees that as death prolonging, not life prolonging. There may be a case here because of the importance of feelings to patients and families to start the dialysis for that reason. Final slide. What's the goal then, as I talked about beginning this? for all staff and all patients and all families and other loved ones to have as their primary goal, if possible, leaving the hospital, walking out its steps hand in hand with all staff members who've treated them, and always feeling that even 20 years later. Thank you very much. I love